Oh, okay. So this is the last video before the prostate cancer meeting, and it has to do with confusion about PSA. I think there's a growing consensus in the medical oncology community about the confusion PSA causes in advanced disease. In clinical trials now with Xtandi, Zytiga, other agents for advanced disease, PSA can give very puzzling findings. You can see a patient who's responding to treatment, their PSA is going up, or progressing, the PSA is going down. So what I'd like to do is give you a intellectual framework to understand how these things can happen. The prostate cancer tumor is not simple. It's a mixed population of the cancer cells in various states. Now, I'm going to paint a very simple picture because it helps explain the point at hand. We have a stem cell population that may be less than 10%, less than 1/10 of a percent of the population. These stem cells are what the cancer regenerates after a complete remission. Hard to kill. Radiation can kill them. Surgery can remove it. The cutting edge of cancer research is how to prevent the stem cells from giving rise to any progeny at all. That's how you get a durable complete remission. Then there's a large population of PSA negative cells that are growing very fast, rapidly proliferating. Now, large in advanced high growth diseases, the population is large. In the slow growing Gleason 6, it's small. It's this population that determines how fast the cancer is growing, but it's PSA negative. Then you have the PSA positive cancer cells. Once a cell starts making PSA, for the most part, they're unable to grow or spread. So they're kind of dead end. This is why cancers with lots of PSA per ounce of cancer are not as aggressive as those with lots of cancer and a little bit of PSA, because the cells that are making PSA aren't going anywhere, doing anything, don't need to be worried about. So studies, a great series of studies out of MD Anderson where they took these tumor populations and put them in a mouse with no immune system and see what would grow. And the PSA positive cells, you put them in there and you might get a little nubbin, but not much. The PSA negative rapidly growing population could establish a mass, but not spread. And the mass would reach a certain size and stop. Put the stem cells in, silent interval, and then the whole cancer gets created, this whole population, and it metastasizes. Now, the stem cells they extracted were from a Gleason 8, and the tumor that was established after stem cells duplicated the patient pathology. So what happens to the PSA in treatment depends on what happens to various populations. If a cancer drug causes all the PSA negative cells to stop growing and make PSA, the PSA is going to go up, although the cancer is now under control. If a drug kills the PSA positive cells, but not the negative cells, you can see a PSA fall, but have very little clinical benefit. So some things that happen, sometimes prostate cancer, when responding to an injury, these negative cells, PSA negative rapidly growing cells, become PSA positive on the way to dying. I think you see this with Taxotere. After the first dose of Taxotere, PSA can surge in patients who are destined to respond well. It's after the second dose, the PSA producing population starts to collapse. So I think what happens with Taxotere is the rapidly proliferating pool, in the sensitive patients, this rapidly proliferating pool switches to PSA-producing cells on the way to dying. I still remember a guy whose PSA went from 80 to 170 and then down to undetectable. So my experience as patients inevitably focus exclusively on PSA, and they can actually be doing well with the rising PSA. Again, for bone metastatic disease, it's now common practice in clinical trials to follow the bone-specific alkaline phosphatase, which measures the formation of a blastic bone lesion, and either the C or the N-terminal telepeptide of collagen, which measures bone breakdown. And these provide an independent assessment. But ultimately, the real arbiter of success or failure is what happens to the bone scan, in a CT scan, measurable disease. Markers cannot replace the measurement of the disease by radiologic means. I hope that clarifies everything for you. Be talking with you multiple times over the next 2 weeks with these videos from the meeting.